Hello, everyone. My name's Shane Harding. I'm going to talk today a little bit about our studies on radiotherapy responses in the mammalian brain. And before I really get into this, I was asked to sort of give you a brief background on myself. So I did my undergraduate and graduate work at the University of Toronto. I studied a variety of things, largely cell and molecular biology, with a focus on radiation biology and how damage to the DNA in cells can cause cell death and how that's really harnessed during cancer treatment. After that training, I spent 5 years at the University of Pennsylvania, and I was one of a group of people who co-discovered how radiation, one way in which radiation can make cells look like they've been infected with a virus, even if they haven't been. And I'll talk about why that's important in a little while. And then I came back to Toronto in 2018 and opened my own lab at the Princess Margaret Cancer Center. And here we continue a lot of this work in my training. We study the molecular responses to DNA damage in cells. And we really try and apply this to understand how both cancer and normal tissues respond to radiotherapy. And I'll explain again why that's important down the road. I'm also involved in a number of different educational programs. One specifically is the STARS 21 program. And in this program, we really try and train the next generation of scientists in interdisciplinary radiation science to sort of foster collaboration and to really expand the world of radiation biology and other aspects of radiation treatment, particularly in cancer. Okay, so I'm going to talk a little bit about brain cancers and radiation today. And I always try to highlight the fact that radiation is very much a ubiquitous form of treatment for cancer. It's used in a targeted way to kill cancer cells, and it's used in more than 50% of all cancer patients. It's used in curative settings quite frequently. It's also used in palliative settings, and it's really a mainstay of cancer treatment. So glioblastoma is a really challenging disease, often is treated with maximal surgical resection and radiotherapy plus chemotherapies like temozolomide. But despite this, what is pretty aggressive therapy, a very few patients survive beyond 10 years. So this is a disease with a pretty dismal prognosis. And despite all of this effort to give patients the best quality of life and the longest life possible, one problem is something called radionecrosis. And this and a series of other side effects emerge from radiation, and they may emerge many years after treatment. So even if you have a successful cure of the tumor, you may have side effects that come about much later. And for example, in treating brain cancer with radiation, some of these side effects, for example, children, some of these side effects can become problematic for sure later in life. So we really try and understand both aspects of this, both how radiation is killing cancer cells and how it can cause damage to normal tissues. And the reason these are important is because of this sort of classical, what we call, there's a dose response curve here and a complication response curve. And so just very briefly, the main premise here is that you can give radiation to very high doses. And as you do this, the higher dose you give, the more likely, that is the percent chance that you're going to cure the tumor, increases over time. So in an ideal world, you could give an infinite amount of radiation and that would cause cure of the tumor. The problem with doing that is that as you increase the radiation dose, you also increase the likelihood that you're going to cause a complication. And in this case, we could call that complication radionecrosis. And so there's a different curve for every type of complication you may have. And so the hope is that there's a therapeutic window here. That's a dose where you can give a reasonable chance to cure the tumor with a very low chance of giving complications. And this is known as the therapeutic window. And so if we want to improve radiation therapy, or really therapy in general, the idea is to enhance the ability to cure that tumor, to control that tumor, perhaps with a lower radiation dose, and reduce the likelihood that you're going to get a complication, perhaps making the dose needed to give that complication much higher. And so the idea is to try and separate this window to give you a higher likelihood of curing the patient and a lower likelihood of inducing complications. So that's really the foundation of a lot of the work in our lab. And we try and understand at the cell biology level and molecular level how we might find ways to do this. And so one of the things we study in the lab is the radiation response, particularly in the mammalian brain. And so here I've shown an example, just a schematic really, of the brain in a mouse. And in my lab, we've developed a method where we basically deliver radiation to a small region of the brain in the mouse. And this is to some extent similar to what's done in patients. And so we deliver radiation to this in this sort of columnar beam to the mouse brain. And then we take, when we sacrifice that animal and we take a slice from this region of the brain, we can then stain that section of the brain histologically. And so that's what this looks like here. And I've shown you here an indication of something called gamma H2AX, and we use this as a marker of DNA damage. So this really tells us where in the brain we've caused damage. And so you can see anywhere that this lights up as brown stain on this image, this is where gamma H2X is positive. And this happens to be particularly in the region that we've stained or that we've treated with radiation. So we've essentially established a model here where we can give focal radiation treatment to the mouse brain, and we can track this over a very long time. These mice actually do quite fine after this. We follow them for months after this treatment. And so we can really understand at the cellular level and at the tissue level what's happening after this treatment. And so this work certainly takes a long time. Some of these side effects take many months to develop. And our immediate steps in this particular area are to understand how specific pathways impact toxicities that develop later on, and to use this to isolate specific cell types in the brain. The brain is made up of dozens of different cell types, to really understand how each of those cells might respond differently to radiation, perhaps suggesting how these side effects, for example, develop. So in general, how might we improve tumor control? So I just talked about complications. We try and figure out how those happen and find ways to mitigate them. The other side of those two curves I showed you at the beginning is to improve tumor control. And one way to do that is to identify patients who are most likely to respond to the treatments. And one of the ways that this is done is to identify patients that have mutations in these genes called IDH1 or IDH2. And patients with these mutations tend to do better. They still have a rather dismal prognosis, certainly with glioblastoma, but they do tend to do better than patients with tumors that are not mutated, that is, their wild type. And one of the reasons for this is that patients with defects in IDH1 or IDH2 have impaired abilities to repair DNA damage, and that causes them to die easier after radiation. So work that I've done previously showed that radiotherapy if we can create the correct signals with radiation at the cellular level, new treatments called immunotherapy become effective. And so this is the idea that maybe now we could combine this new emerging treatment modality called immunotherapy to improve response in these patients. And so we asked, how does IDH1 and how IDH2 or IDH2 mutation impact radiotherapy and immune responses? And so before I really explain to you what we discovered, I have to tell you a little bit about what radiation does to cells. So cells that are treated with radiation have many different fates, and I'm going to show you two particular fates here. And this is a cell I'm going to show you on the left. This is a video that will play in a moment. This is a cell that has been treated with radiation, and it's going to divide. And this cell is actually going to end up pretty much okay after the radiation. It's not going to it's going to have two of them because it's divided into two, but the cells are going to look relatively normal at the end of this process. So I'll give this video a play here. Sorry. Here we are. All right, so again, this cell has been treated with radiation. I'll play this video again. It goes rather quickly. And then it's going to enter division. So this cell divides, and the two cells that end up at the end of this look relatively okay. You couldn't tell any difference whether or not those have been treated with radiation or not. On the right here, this cell is going to enter division. Again, these cells have been treated with radiation too. And this cell is going to look very different at the end of this division. So you can see it divides and it produces these little green small circles around that nucleus. And it turns out that this green, we've stained these cells, the DNA lights up in green. And these small little bodies that are outside of this are called micronuclei. And these micronuclei are unique structures that develop in cells that are treated with radiation. And this is just one fate that can happen to a cell after radiation. And so some years ago now, we showed that this particular protein called cGAS, this is another cell that's been treated with radiation, and it's going to divide and also form these micronuclei. And you're going to see these micronuclei accumulate this protein called cGAS. This video plays over and over again. And it turns out that this cGAS protein generally is meant to recognize viral infections that happen in cells. And so when that happens, in this case, cGAS recognizes these micronuclei and contributes to the production of signals from those cells that communicate with the immune system outside of the radiation field. And what that does is triggers an immunity to the tumor in certain situations. And we've studied this most in mice. So this production of micronuclei and localization of cGAS is really important. So we asked, okay, what happens if we have IDH mutations and we treat these cells with radiation? And it turns out in multiple different cell types, if we compare a wild type to a mutant form of the IDH2 enzyme and treat these cells with radiation, those cells that have the mutated form of this enzyme tend to form far fewer micronuclei than do the wild type cells. It turns out actually that these cells still bring cGAS to their micronuclei. They just have far fewer of those micronuclei to which they can recruit cGAS. So I should also say that we observe in these cells that they have a reduced inflammatory signal, or this immune triggering event in them as well, suggesting that this is an important contributor to radiation responses. All right, so why does this happen? Why are there fewer micronuclei in these cells? So to explain that, I'm going to very quickly explain the process of mitosis and how these micronuclei form. So a cell normally, has a nucleus with DNA tied up in it. When it decides to enter mitosis, it condenses its DNA. You can see these X-shaped chromosomes here. You have binding of what's called a microtubule to these chromosomes, and it essentially pulls these chromosomes apart. And that forms two daughter cells, and then this process repeats anytime the cell is going into mitosis. So at this stage here, it turns out that methylation, these small marks on the chromatin called methylation, contribute to the ability of these microtubules to bind to that chromatin. And so others have shown, and we've shown now too, that loss of methylation is associated with loss of connection of these microtubules to the chromosomes. And it turns out that one of the main effects of IDH is to increase the amount of methylation in the chromatin. And so here what happens, we think, is that the IDH mutation increases the amount of methylation, and this stabilizes microtubule attachment so the chromosomes can properly attach and go to the opposite sides of the dividing cell. Whereas if you don't have this methylation, these chromosomes don't properly attach and they get left behind. And that's how you end up with these small micronuclei, these little pieces of DNA that are away from the rest of the nucleus. So our model then is that in the IDH wild type setting, if you create DNA damage in those cells, they lose methylation within their chromosomes. And that loss of methylation allows micronuclei to form. And those micronuclei trigger a pro-inflammatory reaction that's dependent on cGAS. On the other hand, if you have a mutation, you get hypermethylation of the chromatin. And this allows the chromosomes to separate with more fidelity. And that reduces the overall inflammatory signal that you get in these cells. So this is an interesting molecular connection between how inflammatory signals and potential immune stimulatory signals can is influenced by IDH mutation. All right, so what does this mean in terms of treatment? So we have a model where we take tumors and implant them in the mouse. And when we do this, we can treat these tumors very focally with radiation so that only one of them receives radiation. So we treat on one side of the mice with radiation, and the other side we don't do anything. And we observe these tumors, and we expect the one treated with radiation to go away and the other one to not. But it turns out if we add another molecule to this treatment setting, that's an anti-CTLA-4 antibody or an immunotherapy, we can cause that tumor on the other side of the animal to also go away. And this gives us a measure of a systemic ability of the immune system to remove tumors that were not directly treated with radiation. And I'm not going to go through all of these curves here, but effectively what we've shown or what we observe is that this effect actually only happens efficiently in a wild type IDH setting. When you have an IDH2 mutation where we don't get these micronuclei and we don't get these signals, we see much less effect of this combined radiation treatment, suggesting that IDH2 is an important status marker for whether or not patients might respond to a combined therapy like this. Okay, so I'm going to leave you with a couple take-home messages. One is that optimizing treatment of glioblastoma depends on many factors. It depends on how well we can kill the tumor, whether we're going to get radiation, necrosis, or other side effects from that. And one key molecular feature of glioblastoma and other tumors, it turns out, is IDH status. And this is one determinant of how cells respond to radiation and potentially to immunotherapy. So we're really going to build on these latest discoveries to understand how we might maximize treatment strategies in different ways to capitalize on these unique features of both IDH wild type and mutant cancers. And with that, lots of people to acknowledge. In particular, I'd like to acknowledge Sarah Elkasheff, who's a postdoc in my lab, who's really done the majority of the work that I've showed you today. She's supported by a Brain Tumor Foundation of Canada fellowship, and my lab has been supported by this too. It's something that we're certainly very grateful for. And I'm more than happy to answer questions that anyone might have. You can certainly get my contact information through the foundation, and I'll be happy to address anything that you might be interested in. Thank you. Take care.